Okay, good. So what we're going to do, we're going to assess the pelvis through palpation. Now, if you've already done the x-ray analysis, you know if there's a short leg or a long leg or, what's going on there. You've already know what's going on with the disc. You already know if there's a convex or concave scoliosis or rotational or buckling of the lumbar spine. So what we're going to do, we're going to assess it. And how I assess it is I go down and compare the paravertebrals. When you're comparing the paravertebrals, remember they increase in tone under proprioception. So if you have a convexity, the only muscle that's going to fire off, since she doesn't have conscious control of those, it's going to be on the convex portion. So on doing a scan, you're going to run your hands down either side of the spine, and then you're going to apply pressure in an oblique fashion in this direction. So along the plane line or along the line of the ilium to check the integrity or resistance of that joint, the SI joint. So how it looks like in real world time is I go down either side and checking increase in tone. The beginner can use their hands to check increase in tone. Okay, so you're just checking to see if there's a convexity, concavity, increase in tone, because the increase in tone doesn't necessarily need to be a buckling or rotational malposition. There could be spasm of the intrinsic muscles of the spine, which again, that comes from nerve pressure. So all of these, it's not a muscle problem. It absolutely has to be from a nerve issue. A muscle increase in tone, to actually say that that's a muscle problem, I've never seen it. I've never seen it. So you assess this, then you apply pressure in an oblique fashion in this direction along the plane, and don't do it more than once. So try and apply pressure and apply pressure. Because once you've palpated, if you're going to do it multiple times, you're going to irritate the tissue for one. Second, you're going to change proprioceptive firings. So what you want to do is do this once, check it, and then get your information, and hopefully your skill level will be high enough that you don't have to check it multiple times. Too many times doctors in the field and students will go, wow, it really hurts. It hurts there, right there? That's just silly. Okay, that's gonna be bad for the patient, bad for you, and also the more times you touch the patient, you're going to change the response as well. In the initial response too, if the pelvis is unstable, go in on the lateral aspects about 2 inches below the iliac crest and approximate the hips, or apply pressure on the hips in that direction. What that does when you approximate it, if she says, or the patient says, does that feel better? Or if it changes it, if it says, oh yeah, that makes it worse in the middle, or it makes it better, that means that the pelvis is unstable. And then what you would do is do a trochanter support, and this is going to be ideal. I typically don't adjust until the patient is educated in what a subluxation is and what's going on with their symptoms. What I will do, if they have extreme pain and their pelvis is unstable, I'll give them a trochanter support, and we're going to demonstrate what that is and how we educate the patients on how to do it. We're going to set up a couple of different ways. I'm going to show you how to adjust a PI as opposed to an AS as opposed to a posterior sacrum. And we're only going to be doing setup. I'm only going to do one real world adjustment on her left SI. Okay, it's in a slightly posterior inferior direction, but the rest of it we're just going to demonstrate and set it up. Okay, so lie on your side, face me. Oh, wait, no, I'm sorry, go face down. Oh, I forgot, this one's really cool. Okay, Thompson Technique. When you're looking at this, let's say that you have somebody that can't lay on the side, let's say they have extreme pelvic insufficiency, you may want to do what's called Thompson Technique, which when you're assessing it, you can assess for short leg, and sure enough, she's short on this side. So since we looked at her x-rays and her legs are actually level, what's actually happened is this one has rotated this direction, or this one's rotated this direction. So if you have a short leg, you don't know if it's short, this one could be long. What you do have, you have a torquing of the pelvis, where this one's rotated in the posterior inferior direction, this one's rotated in the anterior superior, okay? So if you look at it, that the leg itself is attached at an oblique fashion on the pivot point, if it rotates anterior, it makes the leg longer. If it rotates PI, or posterior inferior, it makes the leg shorter. Okay, does that make sense? So AS is going to be longer, PI is going to be shorter. So what you can do, again, you're going to use the drop table technique. Since this is rotated posterior, you're going to contact the posterior superior iliac spine and the ischial tube. You're going to lock your arms in and drop down. Now we can do that on her because she is resistance here. And you can set it, lock in, and then it's just a straight drop down. Thompson protocol is going to be 3 settings. Okay, we're going to drop it, drop it, drop it. You can also use, I use a variation of an SOT technique. I have these foam wedges, okay, that I've used. Let's say she's incredibly hot, inflamed. You touch her and she's screaming and she's scared, okay? So you can block her. Okay, and where the blocking goes, again, if this one's rotated AS, we want to rotate it in the posterior inferior direction. So this block will go under the anterior superior iliac spine, and this one's going to go under the ischial tube. So what this will do, this is going to take this pelvis and rotate it in this direction, rotate it in this direction. If she's really hot and inflamed, you can leave her in this blocking fashion. And SOT, sacral occipital technique, has entire protocols on that I recommend you learn or take extra courses, and it's fantastic. What I do, I'll block the pelvis like this. I can ice it up because just her being on this block is an adjustment if she's hot, swollen, inflamed, and tender. Because remember, there's no muscle that crosses the posterior aspect of this. So it's purely ligamentous and tendon tissue. So just by applying that pressure in that direction is going to help stabilize the spine, okay, as well. If you put ice on it as well, that's going to be ideal. If she's really hot, inflamed, tender, but you know you've got to adjust, you can block her for 4 to 5 minutes, ice her, and ice goes through 4 stages, cold, achy, burning, numb, okay, and you leave it on till numb, okay, and then you can come in with the blocks attached, set the drop, and then again, you're going to drop. So the block is helping you. The ischial tube, again, that drop will also rotate it, and this will also rotate it. My pocket is ringing, yeah. That's like Maxwell Smart in the shoe phone. Okay, so, excuse me, let me answer my pocket. So now here, okay, line your side, face me. There's another one. Now, on a posterior, inferior, what you're going to do, you're going to set up, and again, you don't want a lot of torque. You want to maintain pressure on there. I'm not really locking in the pelvis because I don't want to torque it out. I'm going to maintain pressure and then just a tiny drop. Okay, I've already adjusted it, so I don't want to really thrust. But that's exactly what the thrust would be. If it's a posterior sacral base, because remember, when you're looking at the ilium, it doesn't operate in a vacuum. If this thing has gone posterior, it's going to rotate the sacrum as well. Okay, so you can set the PI ilium, you can also set the posterior sacrum, and that's going to be a judgment call. So PI ilium, that's on the posterior inferior iliac spine, the sacrum is going to be a little bit lower, and you're going to want to derotate out or get her a little bit flatter so you have a little greater surface. If it's AS, you're going to contact on the ischial tube, and this one here, you can come up, and that's going to rotate it in the PI fashion. Okay, you can also get the sacral apex coming down. Now let's say that she had an anterior listhesis where it's gone forward. What you want to do, since the sacrum's down here, you want to contact the apex of the sacrum, drop it up so you're hyperflexing it. And think of this, what you're doing, you're driving the base, the L5 or L4, the sacrum, you're lifting it up underneath that anterior listhesis, and then you're going to lift it up and around and then drop it down, again using the drop technique. Here, go on your back. The other move for an anterior listhesis, this one's going to be tough. Wait, let's switch models. Here. Yeah. We're switching models to one that has pants. Okay, so this one, imagine that she has an anterior listhesis. This is a move that's really rare, but in some cases it works really good. It also works on a posterior sacrum. So what you're going to do, you're going to flex up, you contact underneath, okay, so you lift up that sacrum, and you get underneath and contact right, so you give a hole to where that anterior listhesis is. And then you're going to drop down using the drop table technique. I'm not going to do that on you because it's a really powerful move. If you had it, I'd do it, but you don't have it. Okay, so that drop is amazing and powerful. But it's for the anterior listhesis where you rock that pelvis up, you're torquing out the system. And when you drop, you also pull or have a torque on that. So when you're lifting it up, you rock the pelvis up, your hand is on the sacrum, okay? You're giving this one here a little bit more room, so it's a drop and down like that. So you're lifting and driving this whole structure underneath that anterior listhesis. Okay? I know, my pocket is a party. Okay. Any questions?
You go to the sacral base, just pulling,
yeah.
So you distract it first. And
you distract it first, and then the legs are up. So when you're doing this, the legs are flexed up very, very high, and this is your contact. Your line of drive is going to be straight down because you want to rock that pelvis floor coming up and drop it down just like that. So, I mean, there's a lot of contraindications. Obviously, if she was pregnant, if she's obese, had a large stomach, if she has hip problems, there's a tremendous amount of contraindications on all the adjustments, but this gives that one technique that if you're not getting progress, change your technique, because the body is designed to heal itself. If the body is not getting better, it's your fault. Okay, either the patient isn't complying, there's nutrient deficiencies, or your technique has to change, because health is a natural state of the body. So if the body's not getting better fast, it's your fault. Okay? Okay, now what I want to do is demonstrate, rise up, on how to get and apply a trochanter support. So here, if you'll stand up here. So this right here, when you're assessing for it, she's been on a prone position, you've assessed that she needs it, okay? So where it goes is that's the top of the ilium, and I like these, they're only about $7 or $8, but here, oh, you know what, we should just demonstrate the whole thing. Like, okay, here, okay, good, let's go over here. Ready, sir? Go. Okay, so this is how you explain to the patient that they have an unstable pelvis. Now, what's neat is this joint here, there's no muscle that crosses the back half of it, so it never wears out on people. On you, it's wearing out. And that comes from either long-term low back problems or sedentary lifestyle destabilizing this. Now, the typical comment is that the patient will go in, get adjusted, feel better, then an hour later the pain comes back. Now, it takes about 3 to 4 weeks to stabilize this joint. Now, since it's a ligamentous joint, the only way to take it or to repair it is to take pressure off of it and use it. Okay, that's the only way to stabilize that joint, because there's no muscle that you can strengthen. The piriformis causes the anterior aspect, but that's a silly little muscle. Let's fix the actual problem. Okay, so when you look at this, you got to take pressure off of it and use it. So she has to wear a trochanter support when she's standing, walking. When she's sitting, it's not going to do any harm, but it's going to slide up. When she's sleeping, if she sleeps on her side, she can put a pillow in between her legs, which will distance the femurs, and that's going to stabilize the pelvis as well. So we're going to go over a couple of exercises there. But she's going to need the trochanter support to walk between 20 minutes to 2 hours a day, and that'll stabilize it. Should take about 3 weeks. So how we assess it is, come on over here, and this, you go in from the side on the soft tissue and come right down. That's the top of the iliac crest. Thank you. You're doing good. Okay, it's like the flying chiropractor. Okay, now here, so you go in, assess, and come down. That's the top of it. So where this goes is 1 inch below the top. And how this goes on, and these things are very, very inexpensive. They're only about $8, and they're virtually disposable. So it's pulled in, one is tight, and then the second is even tighter. So then she wears this about 20 minutes to an hour a day. Very attractive. The long sword goes in here and the short sword goes in there. I know you're worried about wearing white after Labor Day, but don't worry about it. Okay, so this right here, this stabilizes the pelvis. When she puts it on and takes it off, this comes off first, and then you have to loosen up these secondary supports, and then you put it back on. Now the instructions, how you tell the patient, when she sits, they're going to sit down not like this. They're never going to cross their legs. They need to sit on the edge of the chair with their legs very, very wide, okay? And this will stabilize the pelvis. However, a lot of women find this not comfortable. Not the type of women I date, but a lot of women find it uncomfortable. No, but I mean, because it's kind of revealing. So what you want to do is you can work it where, a lot of people say, well, I can't work like that. Sit like a cowgirl. Okay, that's what I tell them, or sit like a cowboy. So this way you can have a chair without arms, and you can type in everything else. So, have a seat facing me. This way, her legs are out to the side. This is approximating the hips and stabilizing the pelvis. So this will turn sitting into therapy. Any other type of job, because in every sedentary job, every office job, it's going to destabilize the pelvis and it's going to be really a bear because you're going to fix it. The trochanter support will help stabilize it, but what do you do during the day? This right here is it. Okay? Any questions?
That's good.
I know, it is. Thank you.